Thank you so much for the warm welcome. We've all heard about Bill Peckham. He's such an inspiring and incredible person that really advocated for people to have a sense of agency. And in Colorado, a group of us have worked hard to build agency and opportunity for undocumented immigrants with kidney failure. And so in honor of Bill Peckham, I want to start off by telling the story of the person that inspired all of this work and that inspired my own journey into research and health policy. Hilda, the woman that you see here with her 2 boys, was an undocumented immigrant in Colorado. I actually met her just a few years after beginning residency, and at the time she had just been diagnosed with kidney failure. We had to tell her at the bedside that she had 2 options, which were to receive substandard care, so coming to the hospital every 6 to 7 days for emergency dialysis, or to return to her home country. It was so difficult to have this conversation with her. And at the time when we diagnosed patients with kidney failure, we actually had to have them sign a document that stated that those were their 2 options. It was heartbreaking. We had about 70 to 80 other patients, just like Hilda. They would come to the hospital every 7 days, critically ill, nauseous, vomiting from uremia, short of breath because their lungs were full of fluid. And, this is basically how they had to present through our emergency department to be dialyzed. They would be dialyzed, admitted overnight, dialyzed a second time, and then asked to return 7 days later. This was really hard on Hilda, and she was a young mother. Hilda and she was first my patient and then became a very close friend because over 2 years I basically admitted her on a weekly basis. And over those 2 years I got to know Hilda very well. She became a very close friend of mine. And because of the emergency dialysis, she eventually had to stop working. She had been working 2 jobs. One was cleaning offices full-time, and the other was cleaning homes. After not working, she lost her home and became homeless. We eventually found a homeless shelter for women and children who were able to provide them with some wraparound services. But it was really tough. And what I learned from Hilda is that her purpose in life became her boys. At the time, her boys were not going to school. And they weren't going to school because they were worried that if they weren't at their mother's side, that she could become hyperkalemic, that her heart could stop, she would arrest, and no one would be around to call an ambulance. In fact, her oldest boy talks about how he had witnessed her collapse and receive CPR in front of him. It was really tough. So they weren't going to school, and on a weekly basis, they wondered if their mom would survive. And so after a lot of thought and reflection, Hilda decided to stop emergency dialysis. And she did this because she wanted her boys to have an education. She wanted them to have stability. She didn't want them to end up in the U.S. foster system should she die. She had seen so many of her peers die from emergency dialysis. And so after a lot of conversations and thought around stopping emergency dialysis, Hilda expressed that she had 3 wishes. One wish was to find an amazing adoptive family, a family that she knew she could leave her boys with, that would, provide them with an education and stability. And so while we started interviewing families through a couple of adoption agencies, I took custody of the boys, and we met this incredible couple, Chris and Helen, and they basically, when we talk about the adoptive process, they talk about how when they first met Hilda, they walked into the room thinking they were meeting 2 boys that no one wanted, and found themselves crying nonstop for 2 hours with Hilda and her boys when they realized they were adopting 2 boys that were so loved that their mother was willing to die for them. And so together they went through most of the foster to adopt process. Chris and Helen invited Hilda to stay with them, to go on trips with them, until she passed away. Her second wish was to spend some time in the Rocky Mountains because One thing I forgot to mention earlier is that Hilda had fled Mexico at an early age. She had escaped poverty and an abusive relationship. And when she first moved to Colorado, she lived in Estes Park cleaning hotels, and so she loved the mountains. We reached out to the YMCA, and they gave the family a 1-week stay at the Rocky Mountains. So Hilda, the boys, the adoptive parents, they all had a full week of hiking and just fun in nature. And then her last wish was to have a Christmas party, and that's the picture on the right. Hilda wanted music. She wanted to celebrate life. She wanted to invite all of her friends and family. She cooked all the food, which was crazy spicy but delicious. And we danced, and we took lots of pictures. She gave each one of us a basket full of New York peppermint patties because those were her favorite chocolates, and a personal item of hers. She gave me a rosary, a wooden rosary her father had left for her. And so Hilda passed away on Mother's Day in 2014, and her peers, the patients that had come to know her in the waiting room, the clinicians that took care of her, all of us were left in total, utter distress. And it was so difficult to come back to the hospital and to continue to provide this type of care for patients. And what was difficult about it is we would see these patients come through the emergency department short of breath, nauseous, vomiting, couldn't speak in full sentences, received 2 dialysis sessions, and they were suddenly able to participate in life. So it was, just extreme moral distress. And after Hilda passed away, a few of us tried to do some advocacy at the state level and within the hospital in the city, but we couldn't really get very far because really what was missing was data that could inform policy change. And so I started reading everything possible on this issue and came across a narrative written by Dr. Straub, who at the time was CMO for CMS. And in this narrative, he talks about how we needed more evidence-based data, cost analyses, to inform policy change throughout the country. And so at that time, I had been an internal medicine hospitalist for about 6 years. I had no research experience, but I decided I just could not go back to the hospital and continue to provide this type of care. So in that moment, I decided to fully transition to research with the sole purpose of changing health policy in the state. And so just a quick background, there are about 6,000 to 9,000 undocumented immigrants in the country with kidney failure. The majority tend to be male, they're young, in their 40s, and the majority have lived in the country for at least 5 years before being diagnosed with end-stage kidney disease. Across the country, U.S. citizens have access to kidney replacement therapy because of the 1972 Medicare end-stage renal disease entitlement program. But for undocumented immigrants, care varies. They're excluded from Medicare, most Medicaid programs, and the provisions of the Affordable Care Act. And so across the country, some states have modified their emergency Medicaid program to include dialysis services or to include end-stage kidney disease as a qualifying condition. And so care varies throughout the country. You may be familiar with EMTALA, the Emergency Medical Treatment and Active Labor Act. This is federal law that basically states that reimbursement for care cannot be received for a patient unless they're in critical condition. And so what has happened is each state has created their own emergency Medicaid program, but some states use the exact EMTALA federal language, and others have modified the conditions. And so Washington State is an example for the rest of the country. You all include dialysis services as a qualifying services for emergency Medicaid, and so patients in your state, undocumented or not, can receive standard of care dialysis. However, throughout the rest of the country, and at the time when Hilda died, most states did not provide standard of care dialysis. And so armed with, I guess I should say, grit and anger and, inspired by Hilda, my patients, my partners, community-based organizations, and I decided to begin a body of research around this to describe outcomes faced by undocumented immigrants who are forced to receive emergency dialysis. We began our work with qualitative research. We began by interviewing undocumented immigrants who rely on emergency dialysis. So I basically sat with them one-to-one, 20 patients, and asked them what life was like receiving emergency dialysis. And they basically described, weekly death anxiety. Many of them had received CPR, so they described pain because they had received chest compressions a number of times. They described a huge psychosocial physical burden because they had to wait for their symptoms to accumulate every 7 days to be dialyzed. One thing I didn't mention is that if they came to the hospital sooner than 7 days and they didn't meet critically ill criteria, meaning they had to meet a certain potassium threshold or other clinical objectives, they were turned away, even if they were visibly ill, from the emergency department. And that was because we only had a certain number of dialysis chairs. So this was really tough for patients. We also interviewed caregivers. Caregivers were young, just like patients in their 40s, and what they primarily described was the distress in their children. Sometimes their children had to drop out of school to provide language interpretation in the hospital, caregiving support at home, and sometimes to work as well. And a couple of families described how their kids had attempted suicide because of the psychosocial distress that they faced. And then the third qualitative study, we interviewed clinicians, interdisciplinary clinicians, 25 in Colorado and 25 in Houston, Texas. And they described drivers of burnout. They described feelings of moral distress from witnessing needless suffering and high mortality. They described frustration with having to treat people differently based on their immigration status or insurance status. Clinicians from Texas resented the fact that this was called compassionate dialysis when it was anything but. We also conducted some quantitative studies. We compared mortality and utilization between undocumented immigrants who receive emergency dialysis in Colorado and Houston, Texas, to undocumented immigrants that receive standard of care dialysis in San Francisco, and found that mortality was 14-fold worse 5 years after beginning dialysis, and utilization was 10-fold worse. Another group in Dallas, Texas, also conducted a retrospective cohort analysis, and they were able to do this because a large number of their patients received subsidies towards private health insurance off the exchange, and they found that undocumented immigrants that rely on emergency dialysis have a mortality that is 5-fold worse after 1 year, and there's a cost savings of $6,000 per person per month. And so, as I mentioned, this was all inspired by Hilda. And from the beginning of this work, from the types of research questions to the advocacy, engaging local and national media, this was all done in partnership with our patients and our community-based organizations and some of our health policy stakeholders. And so together we published, together we presented to media. My patients did this at the risk of deportation. And eventually, in August of 2019, our state Medicaid agency, it was August of 2018 that they announced it, but the change took effect February 1st of 2019. But our state Medicaid agency decided that they were going to include end-stage kidney disease as a qualifying condition under emergency Medicaid. And so this was about 4 years after Hilda passed away. And it was such a huge win. One thing I don't often mention is that just before Hilda passed away, we had gone out to eat dinner. And I remember when we had dinner, she said, I'm going to eat all the foods that are high in potassium that I never get to eat, because she was going to get dialyzed the next day and then she was going to stop. And I remember we sat down and she told me, Lily, you have to change this. You have to continue to work with our patients and our community partners to change this. And so this has been just an incredible change. These pictures are her boys. The picture on the left is from a bench that we dedicated to Hilda just after she passed away. And the picture on the right is from 2020. Her boys, her oldest had graduated from high school and was getting ready to go to college. For our patients, this has been a huge win. It's hard to tell from this picture. This is at my house, Christmas 2019. They looked amazing. A lot of them, while they were receiving emergency dialysis, had to stay on oxygen. They were swollen all the time on multiple antihypertensives. And after the change, the color of their skin, their ability to talk, their energy, all of it changed. And so this was a celebration with our patients. And because I didn't want to stop with a policy change in Colorado, we've continued to publish on this issue. So this is a pre-post intervention study. We basically conducted mixed methods. We conducted qualitative interviews, assessed quality of life, satisfaction, and symptom burden before patients transitioned from emergency to standard dialysis. And after patients transitioned to standard dialysis, we re-interviewed them and found that patients had improved in all 5 quality of life subscales using the KDQOL SF-36, and 7 out of 11 symptoms had statistically improved. And qualitatively, like, that was what was most rewarding. Patients talked about how they just appreciated not being deprioritized and felt like they could actually have full-time jobs. They could come home from work and have enough energy to play at the park with their kids and help them with homework. And so this was very meaningful for our patients. We also published the manuscript on the right. I co-authored that one with our state Medicaid director, and in that manuscript we basically outline the steps that each state can take to create the same change. And then the letter on the right was authored by the National Kidney Foundation. So this is a letter addressed to all state Medicaid directors. And in this letter, they basically outline the steps that each state can take in addition to providing sort of the qualitative and quantitative data to support this type of change. And what's really cool is that we built more solidarity around this issue by reaching out to other large physician and patient organizations. So we have several signatories on this letter, including the Society of Hospital Medicine, the Society of General Internal Medicine, Endocrine, ATS, a lot of different groups, American Society of Nephrology too. And in Colorado, I think our state Medicaid agency is probably used to me reaching out to them. One of our nephrology fellows, who you may be familiar with, Dr. Katie Rizzolo, she put together a policy brief soon after joining Colorado, and in this policy brief outlined the reasons patients should have access to home dialysis. We also included an economic analysis and presented it to our state Medicaid agency. They took this information and conducted an internal cost analysis and found that this was cost savings within a year. And so they actually just expanded to home dialysis in Colorado beginning January 2022. And the second big change this past year is that our patients with end-stage kidney disease only need to reapply for emergency Medicaid on a yearly basis, because before this change, they had to apply for emergency Medicaid benefits on a monthly basis, and so oftentimes our patients would lose their benefits. And so these 2 changes were huge for our undocumented kidney patients. And then Hilda, she was the catalyst for this sort of research health policy journey for me. And what has become of the health policy journey for me has included working alongside our nonprofit community-based organizations to continue to create change, especially for those communities that are invisible in our state. One huge win, just as of 3 months ago, is HB 1289, Cover All Coloradans. This basically creates a state Medicaid program for undocumented immigrants. It's the first ever. And undocumented immigrants under the age of 18 and postpartum persons for at least a year postpartum will now have access to our state Medicaid. And then separate from that, a lot of other really cool legislative changes, including the Colorado option and then the Health Insurance Affordability Enterprise. And that's basically like our state's Affordable Care Act, for lack of better words. But this basically creates private health insurance for 10,000 undocumented each year. This work would not be possible with all of the incredible stakeholders, patients, health policy stakeholders, leaders and grassroots folks from nonprofit community-based organizations. And as I mentioned, our work does not stop here. We are now working on community-based interventions to improve the well-being of U.S. citizens and undocumented immigrants that receive standard of care dialysis. We're also working on a proposal to improve transitions to recommended kidney replacement therapy for all people. And so we are all just sort of continuing to build on this work so that we can eliminate disparities. And so with that, I want to end with a quote from Bill Peckham. As I mentioned, he was an incredible advocate and truly empowered people to live life, that dialysis should not stop them. And he sort of built a sense of agency for folks. I want to end with his thoughts about life. He says, "What's fun about getting old? How about the opportunity to see how the challenges of today play themselves out? How about having the opportunity to enjoy the fruits of your labors? How about having more time to improve the world? How about the opportunity to enjoy another sunset and then another sunrise? I enjoy the struggle. My idea of heaven is an imperfect world complete with great needs and great opportunities to affect change." And so I want to leave you with his words, and thank you so much for this opportunity to tell you the story of Hilda and the change that we've created in Colorado.
This is the first speaker who got a standing ovation. So on behalf of the Center for Dialysis Innovation, we want to give you a plaque thanking you for your talk. And we want to also invite you to stay for a moment because there may be some people who want to ask some questions. Okay?
Thank you.
Thank you, Lily.
Lily, I can't say enough. Thank you so much for the work that you have done for us and the example that you've set for us. And thinking of an example, you have set a template for agency for physicians to advocate for patients who are marginalized from care. I often interact with my colleagues, and we often feel helpless about doing the type of work that you've done. And so I would encourage you to work with others to even come up with a curriculum that is based on the template that you've set that can be integrated into our training programs. Because those of us who are physicians and, more importantly, aspire to be physicians can learn lessons from what you've just taught us. So we actually do have some agency to be able to make a change in getting marginalized folks in our community care. And so I encourage you and your group to do exactly that.
Thank you, Don. I so appreciate that comment. And I have to say, this is my first time meeting Don in person. It has been such an honor to meet so many of you in person at this meeting. I've been presenting an advocacy model throughout the state, and if you're interested, I'm happy to present to you. And we did actually just submit it for publication. But it is an advocacy model that clinicians can sort of take to apply their advocacy question or their advocacy research, because really what we should be doing now is research that can eliminate upstream structural drivers of health inequities. We have to be able to translate our research to create change. That has to be mandatory, I think. How is this going to inform the well-being of our patients? When over 50% of patients with end-stage kidney disease are racial and ethnic minorities, they have to be at the table, and we have to think about how this is going to create change. And so with that in mind, I think funding agencies need to urge individuals to consider the upstream drivers of structural racism when they're looking at research. How are we making sure that we include the populations that have these conditions, and how can we make sure that they are at the table so that when innovations become available, they are not excluded?
Dr. Wieringa from the Netherlands. So I must compliment for your compassion. And both Dr. Kolff and Dr. Scribner would have been proud of you, because they did the same things, and they would have loved to be in this lecture. And you just showed us that many times we think we are in the middle of this song. That's just the way it is. Some things will never change. But you just showed us, but don't you believe them. Thank you.
Thank you. Thank you. One thing I forgot to mention is that since Colorado's changed, 6 other states have changed, which is really exciting. And there are more states that are working on this. And it just takes a group of interdisciplinary clinicians, researchers, stakeholders interested in creating change.
Dr. Cervantes, my name is Brigitte Schiller. We had some connection via Twitter, and you're just taking my breath away here. I wanted to compliment you and encourage you to follow this incredible courage that you're bringing. I came about 30 years ago as an immigrant to this country, as a nephrologist. And I remember sitting in a meeting where somebody told everybody that it's okay to do undocumented in the emergency room, and then you sent them home. And nobody said anything. And I was a young immigrant, and I thought, wow, how can anybody think that that's okay? So I want to encourage all the people in this room that this is the courage we as a country need. Healthcare for everybody should not be a political effort. It's a sign, a moral sign, how a civilization cares. And we're the country who should do better at that. Thank you so much.
Thank you.
We have a question virtually. I've noticed that most of the patients appear to be Latinx. Living in Texas, I can certainly understand this being a situation. However, I wonder what other immigrant groups are usually affected by this in other states.
Thank you. Yes. In our work, when we've included Texas and San Francisco, a little over 90% are Latino or self-identify as Hispanic. And I would say closer to 5 to 8% are non-Latino, with the majority being or self-identifying as Asian. So there is a mix, and I think it just depends on the state.